Hello, and welcome to Desera Clinical Education's Oncology podcast. I'm your host, Kemi Obajimi. Today's episode features expert perspectives on emerging therapies for patients with HER2-positive gastroesophageal adenocarcinoma and biliary tract cancer. This episode is part of a larger educational program titled Innovations in HER2-positive gastroesophageal adenocarcinoma and biliary tract cancer, a practical skills course on new and emerging targeted therapies. This podcast features Dr. Amit Mahipal, Chief GI Medical Oncology Program, Professor of Medicine, and Ruth and Goodman, Endowed Chair in GI Oncology at the University Hospital's Sidman Cancer Center, Case Comprehensive Cancer Center at the Case Western Reserve University in Cleveland, Ohio. Dr. Shubham Pant, Professor of GI Medical Oncology, Department of Gastrointestinal Medical Oncology, and Department of Investigational Cancer Therapeutics, Division of Cancer Medicine at MD Anderson Cancer Center in Houston, Texas. They will be providing a brief overview of biliary tract cancer and gastroesophageal adenocarcinoma, and discussing notable findings from a recent survey of healthcare professionals on gastroesophageal adenocarcinoma and biliary tract cancer, case studies on the recommended management of patients with these diseases, emerging datasets on HER2-directed therapies in gastroesophageal adenocarcinoma and biliary tract cancer affecting clinical practice, challenges faced by healthcare professionals in the management of patients with these diseases, and key ongoing trials of HER2-directed therapies in gastroesophageal adenocarcinoma and biliary tract cancer. For more information on Dr. Mahipal and Dr. Pant, along with a link to the complete program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
Hello and welcome to Emerging Therapies for Patients with HER2-positive gastroesophageal adenocarcinoma and biliary tract cancer. I'm Dr. Shubham Pant. I'm a professor of GI Medical Oncology at the MD Anderson Cancer Center in Houston, Texas. And with me is Dr. Amit Mahipal. Please introduce yourself.
Hi, everyone. I'm a professor of GI Medical Oncology at Case Western Reserve University and University Hospitals.
Today, we are going to discuss a brief overview of biliary tract cancers and gastroesophageal adenocarcinoma. I'm going to discuss the key clinical takeaways from Think Tank and the survey with Amit. We're also going to discuss a couple of very important case reports, which is a brief case in biliary tract cancer and a brief case in gastroesophageal adenocarcinoma. We're also going to discuss emerging data sets affecting clinical practice, persistent needs identified in recent serial assessment surveys. Also going to discuss challenges faced by healthcare professionals in the management of patients with biliary tract cancer and or gastroesophageal adenocarcinoma. To kick off this podcast, Amit, can you give a brief overview of what gastroesophageal adenocarcinoma is?
Sure. So gastroesophageal adenocarcinoma is a group of diseases that originates either in the stomach, esophagus, or gastroesophageal junction. And the anatomy matters specifically in terms of surgical options, especially if these patients are diagnosed at the early stage. The way we treat lower esophageal or gastroesophageal junction cancer is a little bit different than gastric cancer. However, from practical perspective and basically from the systemic therapy perspective, for patients with advanced gastroesophageal adenocarcinoma, they're treated regardless of if they originate in stomach or in the esophagus or GE junction. So there's no difference. That's why we club them as gastroesophageal adenocarcinoma. Unfortunately, for patients with advanced GEA, there is a very poor prognosis. And we have very low 5-year survival rate in single digits, basically. So there's a lot of room for improvement. And recently, there has been a lot of biomarker development, which is guiding our first-line treatment for advanced gastroesophageal adenocarcinoma. Shubham, I'll ask you if you could describe what biliary tract cancer means.
Just like gastroesophageal adenocarcinoma, the majority of biliary tract cancers are unfortunately found in stage 4, where the prognosis is poor. Currently, for the frontline therapy for advanced cancers, we treat them with gemcitabine cisplatin, with a checkpoint inhibitor, normally either durvalumab or pembrolizumab. And in the second line setting, if they do not have any targetable alterations, we normally give them chemotherapy. But the exciting thing recently in biliary tract cancer has been the advent of targeted therapies. So we do the next generation sequencing, and there are different targeting therapy options. In our podcast today, we are also discussing really interesting newer therapies for biliary tract cancer, specifically for HER2 positive or HER2 amplified disease. And we're going to discuss few options which have recently been FDA approved for this disease. So 5-year outcomes are not great, but we have a lot of emerging options for our patients. Now, I'm going to discuss some survey responses from healthcare providers who treat patients with biliary tract cancer and or gastroesophageal adenocarcinoma. So the first question we asked was, which specific cancer type do you think is commonly associated with HER2 positivity? And 43 respondents gave the response, and the different answers were gallbladder cancer, extrahepatic cholangiocarcinoma, intrahepatic cholangiocarcinoma, gastroesophageal cancer, none of the above, or I'm not sure. And the most commonly picked was gastroesophageal adenocarcinoma. And the second most commonly picked was gallbladder cancer. I think both are correct. The second question was, in your opinion, which of the following indicates HER2 positivity for patients with BTC and or GEA? And folks answered either it's IHC 3+ or IHC 2+ and FISH positive. Amit, I'm going to pause here, ask you about your thoughts on this answer of IHC 3+. What do you think about IHC 2+ and FISH positive as it pertains to gastroesophageal adenocarcinoma and for biliary tract cancers?
Sure. So I think from the FDA approval perspective, at least for the gastroesophageal cancer, so patients who are IHC 3+, they're considered HER2 positive. For patients who are IHC 2+, they require additional testing called FISH testing. And if they are FISH positive, then they are clubbed into this bucket of being HER2 positive and can be treated as for HER2-directed therapies. Most of the pathology, there is I would say, reflex testing. So if there's IHC 2+, they do automatically should get FISH testing. But if that's not the case, I want to make sure that IHC 2+ is not considered positive. So those patients should get FISH testing and then treated with HER2-directed therapy if they are FISH positive.
The third question was, which subtype of BTC do you think is the highest level of HER2 expression? And the answers were gallbladder cancer, extrahepatic cholangiocarcinoma, intrahepatic, none of the above, or I'm not sure. Majority of respondents said, I'm not sure, which is understandable because we have to remember gallbladder cancer and biliary tract cancers are rare cancers overall. And we don't see a lot of them in the US. But to answer the question for our respondents, the number one is gallbladder cancer, actually, when the HER2 positivity can be up to 30%. So if you have a patient with advanced gallbladder cancer, definitely do test them for HER2 positivity. Technically, you should do that for all biliary tract cancer patients, but gallbladder cancer specifically has the highest level of HER2 expression. Coming to our fourth question, we asked, in your clinical practice, are you retesting for HER2 status before recommending the next line of therapy after disease progression for your patients who have previously been exposed to HER2 target therapies? And the majority, 55%, said yes. Amit, what do you think about this as far as BTC is concerned and GEA is concerned?
Yeah, I think retesting for HER2 before starting next line of therapy is very important, especially in gastroesophageal junction cancer. I would say it's important when you're treating someone with a HER2-directed therapy. So we'll talk about first-line treatment for gastroesophageal cancer, but typically for advanced gastroesophageal cancer who are HER2 positive, we tend to treat them with HER2-directed therapy plus chemotherapy. And if these patients progress, at that point, we would definitely recommend testing for HER2 status again. And then if they are HER2 positive, then consider appropriate anti-HER2 therapy. I think same in terms of the BTC, I mean, we don't have any anti-HER2 therapy yet approved in the first-line setting. So if they are HER2 positive at baseline and then you treat them with chemoimmunotherapy as a standard of care first-line therapy, I don't think those patients need to be tested again for HER2 positivity. I think we can assume since these patients did not get any anti-HER2 therapy that they'll probably be HER2 positive and can be treated with anti-HER2 therapy.
And you're so right, Amit. That's exactly right. That in GEA, it's more nuanced because they normally get something like trastuzumab frontline, whereas in BTC, they're not getting a HER2 target therapy frontline. So it's okay not to retest if they're HER2 amplified in the beginning. One of the other questions was, in your clinical practice, which of the following sample types do you use to test for HER2 positivity in your patients with BTC and or GEA? About 40% said ctDNA, about 65% said tumor tissue, about 16% said, I do not test for HER2 status. You should be testing for HER2 status. So I'm going to correct it right there. And I'm not sure was about 16%. So first, to answer some of these questions is we should be testing all our GEA and BTC patients for HER2 status. That is very, very important. But Amit, what do you use normally in your practice? Tumor tissue, ctDNA, pros and cons of each?
Sure. I mean, I think ideal is tumor tissue. So we do need to get tumor tissue. I mean, there's no doubt that ctDNA can miss HER2 positivity, and then tumor tissue has higher sensitivity, I would say. If the ctDNA is positive, most likely tumor tissue will be positive. So that's positivity. However, there are many cases where tumor tissue is positive and ctDNA can be negative. So at least at the first line, at least at the first time of diagnosis, for sure, I would recommend doing a tumor tissue testing. If you don't have enough tissue, I would even recommend repeating a biopsy. So just to make sure we are not missing any HER2 positivity, because that could have great impact on how we treat the disease and the long-term survival outcomes. The question becomes, especially in GEA, these patients who were initially HER2 positive got treated with anti-HER2 directed therapy, and then now they're progressing. What do you do at that time? And I think, again, I would advocate, if you can do biopsies, if it's feasible, safe, I would advocate for repeating a tumor biopsy. Obviously, and sometimes if that's not feasible, ctDNA could be used as a surrogate marker, but just do remember that if ctDNA is negative for HER2 amplification, that does not mean patient is not HER2 positive.
Yeah, and I completely agree with you, Ahmed, that I really go with the tumor testing because I think that's the most reliable, as the gold standard of testing in these patients. But sometimes when it's not feasible, it's not in a place where the interventional radiologist can really say, I can do this safely, then we think about doing ctDNA testing. But I completely agree with you that tumor tissue should be at the top of that list. And then if we cannot do that safely for whatever reason, then ctDNA comes in play.
Now we're going to talk about a brief case for a patient with biliary tract cancer. So a 65-year-old gentleman who was diagnosed with metastatic gallbladder adenocarcinoma. He had a 30-pack year of smoking history, had stopped smoking about 10 years ago, and other comorbidities, including hypertension and diabetes. He also has a history of interstitial lung disease or pneumonitis and required treatment with steroids. So patient was diagnosed about 7 months ago, was on first-line treatment, and unfortunately now have disease progression and was found to have several new lesions in the peritoneum. Patient have excellent performance status with a ECOG performance status of 1, and all his labs are within normal limits. Shubham, in this patient history, what are the characteristics that really help you make the next treatment decision for this patient?
I think there are a number of things. First of all, I'm going to look at the next gen sequencing, like what is the molecular targets I can utilize for this patient. That's very important. In that, I'm going to look for FGFR fusion. I'm going to look for IDH1 mutation, and I'm going to look for HER2 amplification. I think those things are very important. The most important is, how does the patient look? What's the performance status? I know you said performance status was 1, but the patient had a performance status of 3. That's very important to know because that would really guide our further therapy. Should we continue to treat this advanced patient, or should we think about things like palliative care options for this patient, essentially? But this patient seemed to have a good ECOG of 1, so I think I would go towards the next generation sequencing in this patient, trying to see if I can really give them a molecular target therapy at this stage.
Talking about NGS, like when do you do the NGS testing? Do you do at the time of diagnosis or after they're progressing in the first line? What are your thoughts on that? And when should we get those results?
I think we should do it as soon as we see the patient in the front line. And there's a reason for that. Sometimes folks are like, hey, there are no approved drugs in the frontline setting, so why don't I do it in the second line? But what we have to understand is, let's say you have a patient and you're treating the patient with chemoimmunotherapy and they progress. But sometimes the progression is fairly rapid. Then you're biopsying, then you're waiting for another month for it to come back, and then you might miss a clinical trial for the patient. So if you have that NGS right there, They might have a KRAS mutation. You put them on a RAS-directed trial, or they could have, an FGFR, and they could go on an FGFR trial. I know they're approved agent, but there are trials also out there. So I think it's very important on the decision making that you need those results at that time for the patient to really make a game time treatment decision on this patient at that time. Now, if you wait for another month, you're getting a biopsy, and that's another 2 weeks to get a biopsy. Call my favorite interventional radiologist to expedite that biopsy. Who knows, by that time, the patient are on blood thinners, and then it further complicates matters. And then you're kind of delaying things, waiting for it. Maybe there's a clinical trial. They might not be able to get on a clinical trial. So I want my information upfront. I want it when the patient is there. Now, what do I normally do? And we've discussed that before. I'm a big proponent of obviously tumor tissue for getting that whole next-gen sequencing, for getting that RNA sequencing, for that FGFR fusion, trying to find other targets that we might not have approvals for, but we might have clinical trials for. But if I'm not able to get a tumor tissue safely, then I go with ctDNA analysis, but I really try to go with a tumor tissue. And so I think it's important to have that information available. And if we cannot do it, that's different. Sometimes we just cannot get the tumor tissue and we do the ctDNA and nothing shows up. So I wait for something new to metastasize, and if I can biopsy at that time, but I'm always looking for lesions to biopsy if I can do it safely.
Great. Yeah, I mean, stressing the importance of tumor tissue biopsies for NGSs, cannot be stressed enough, I would say. So something we have adopted in our practice is actually when we have see the patient first time, we would do both tumor tissue as well as ctDNA at the same time. So again, just to expedite, as Shubham, you said, like there are a lot of trials that are out there. It's really important to know those results. But again, the tumor tissue remains the gold standard. We talk about the different biomarkers, and let's assume that this patient has HER2 IHC3+ and did not find actionable, targetable alteration, although that keeps on changing as we get more and more therapies, but negative for like FGFR fusion or IDH1 or KRAS. What would be your next line of therapy in that case?
If the patient is IHC HER2 3+, we have two different options for the patient. We have trastuzumab deruxtecan that is approved, also zanidatamab, which is a very unique kind of a drug. It's a biparatropic bispecific. So what that means is it binds to two areas on the HER2 protein. It's on extracellular domain 2 and 4, essentially. So binds it in two areas. And that leads to certain efficiencies of the drug. But the trial which got this approved was a trial called Horizon BTC-01. And this is a unique trial. So the other drugs which have been approved or are part of the NCCN guidelines were part of a basket trial. That means it was trying different malignancies. So it could have been biliary tract cancer. It could have been ovarian cancer, some other cancers. However, the Horizon BTC-01 was a biliary tract cancer only trial. And that's important. It was a global trial. The efficacy analysis was done in about 80 patients who were HER2 amplified. And this was defined as HER2 IHC3+ or a HER2 IHC2+ and ISH positive. That means in situ hybridization positive. The maximum benefit was seen in the IHC3+ patients. In the patients who were IHC3+, the overall response rate for these patients was 52% with a disease control rate of 79%. Not only that, the patients who got a response, it's important also to have a good duration of response. That means there's sometimes, as you know, in our trials or in when we're treating patients in real life, the patient can get a good response with their first scan, but they can be progressing with the next scan. So though they've had a quote unquote partial response, it might not be clinically beneficial for the patient because they could not hold that response for longer, or the drug, unfortunately, could not hold that response for longer. But the duration of response, that means the patients who were responding, how long were they responding for? The median was about 14.9 months, which I think is very clinically relevant for these patients. The progression-free survival in these patients was about 7.2 months. So important data and exciting data for our patients, and which led to the approval of this therapy.
So just to follow up on this patient, as you clearly stated that the patient would be a candidate for zanidatamab and patient did receive zanidatamab. Do we need to pre-medicate before giving zanidatamab infusion? What are your thoughts on that and the reason for that?
Great question, Amit. So it's actually in the package insert. Treat patients with zanidatamab, look in the package insert. What happened was in the phase 1 setting, there was an increased risk of infusion reactions. A majority were early on, grade 1 or 2. In the clinical trial, it was part of the trial that they received pre-medication before zanidatamab. So acetaminophen, diphenhydramine, hydrocortisone, 30 to 60 minutes before administration of zanidatamab. And that's part of the package insert. So yes, I would encourage folks to pre-medicate before zanidatamab, make it their standard of care or their SOP when they're giving zanidatamab.
Great. Yeah, I think most of us use some sort of EMR system, and it's automatically these pre-medication are included in that system.
Things thankfully have been made easier for us in some ways.
We don't
Some
have
ways
to-
harder, some ways easier.
As I mentioned, this patient was started on zanidatamab. About a month into treatment, this patient gives a frantic call that he's having a lot of bowel movements. He had 8 episodes a day of diarrhea. Is that a common occurrence, a common adverse event and how would you manage it?
Yeah, it's one of the most common adverse events of zanidatamab. Most folks don't get this much diarrhea. They get less diarrhea. Now, you have to separate them out because gastroesophageal adenocarcinoma that we'll talk later, in that it's with chemotherapy, so you have to give prophylaxis. But if you're giving single agent zanidatamab for biliary tract cancer, you really don't have to give prophylaxis. However, I talk to the patients, I talk to them, I said, think about like irinotecan. When we're giving irinotecan regimens, we talk to the patient. We say, hey, here's some Imodium. It's over the counter. Keep it with you. First sign of diarrhea, you took 2 pills of the Imodium and you take 2 every 2 hours till the maximum of Imodium, which is, about 16 milligrams. So you kind of do follow up with Imodium. I tell the patient to call us immediately, stay hydrated. You might have to add on a second agent called Lomotil, sometimes, which is a prescription drug. But honestly, I've seen it well managed. I had one patient who got a decent amount of diarrhea with 20 milligram per kilogram. So you can dose reduce them to 15 milligram per kilogram, which is a lower dose of this drug. And the patient did well after that. So there is diarrhea, but it's very manageable with this drug.
Yeah, I think it's important to know about these unique toxicity of some of these new or novel agents that we use and manage them appropriately, and providing that patient education upfront could help a lot. Can you also provide a brief overview about efficacy from the survival perspective? I know you talk about response rates and duration of response, which was amazing in the Horizon trial with over 50% response rate and duration of response of over 14 months. And also talk about the most common treatment-related AEs apart from diarrhea.
We discussed the duration of response and the progression to survival. In this trial for IHC 3+, the patients had a median overall survival of 18.1 months. You and I treat a lot of biliary tract cancer. This is significantly higher than you would think that you would get with chemotherapy, because these patients have been pre-treated with some kind of therapy. These are not treatment-naive patients. So that's very encouraging. Essentially, the main side effect, as we talked about, was diarrhea and infusion-related reactions. But infusion-related reactions can be mitigated with pre-medications. Rarely, patient can get ejection fraction decrease. We have an echo or a MAGA scan that we normally would do with any other HER2 targeted therapy. And some patients, small percentage, can get nausea and vomiting, but they were mostly grade 1 and 2.
Thank you, Shubham, for that overview.
I'm going to talk about the second brief case study. Approximately 5 years ago, a 44-year-old man of African descent was diagnosed with chronic heartburn. Lab test, endoscopy, and initial biopsy of the ulcer failed to reveal presence of malignant cells. For several years, heartburn was treated, successfully kept under control. And then the patient now presents with a stage 4 gastroesophageal adenocarcinoma with lymph node and liver involvement. Unfortunately, the patient still has a good ECOG performance status of 1, no cardiac dysfunction, and has an echogram ejection fraction of 60%. Amit, given the patient's history, which of the characteristics are important to make the next best decision for this patient?
Here, it looks like it's a young patient who is very healthy with an excellent performance status, no real comorbidities. So would be an excellent candidate to receive systemic therapy. I think it was important to talk about the heart functions, like EF of 60% is in the normal range. So that will not restrict us from giving therapies that could potentially have adverse event of cardiac function.
So what would you recommend as a next best treatment approach for this patient, and why would you do that?
The treatment for gastroesophageal cancers has changed a lot. Now, before we do the first-line treatment, we need to know the biomarkers. I mean, this is something new to cancers, I would say, in general, where initially we'll just do some sort of first-line treatment, and then based on the biomarkers, we'll decide the second-line therapy. Gastroesophageal cancer, this has changed totally. We need to know some of these biomarkers before we can decide what's the best first-line therapy would be. And these could include different immunohistochemistry markers, include microsatellite status, HER2, PD-L1, and now recently Claudin 18.2 as well. So we need to know those biomarkers at least to know how we select the first-line treatment options.
You're right, Amit. Early testing is very important, especially in patients with advanced GEA, because that can change the way you treat these patients, depending on all the important biomarkers you talked about. Amit, for this patient, what will be the first-line optimal therapy?
This patient underwent biomarker testing. So it was a microsatellite stable. It was HER2 3+, PD-L1 positive, and negative for Claudin 18.2. So a couple of important biomarkers. So both HER2 are positive as well as PD-L1. Based on the Keynote 811 trial, this patient would be an excellent candidate to receive trastuzumab plus FOLFOX plus pembrolizumab. So almost like what we call triplet therapy. So you have a chemotherapy as your base, and then you're adding pembrolizumab as an anti-PD-1 therapy and anti-HER2 therapy of trastuzumab. So FOLFOX plus pembrolizumab plus trastuzumab.
Could you talk about why you would treat the way you're treating?
Sure. Almost 15 years ago, there was a TOGA trial that was presented, which transformed how we treat HER2 positive gastroesophageal cancers. So in the TOGA trial, they randomized patients into chemotherapy or chemotherapy plus trastuzumab for patients who are HER2 positive advanced cancer as a first-line treatment options. That trial showed median survival improvement from 11 months with just chemotherapy alone to 13.8 months with addition of trastuzumab to chemotherapy. The response rates also increased from 35% to 47%. More recently, Keynote 811 trial was presented, which showed benefit of chemotherapy plus pembrolizumab plus trastuzumab compared to trastuzumab plus chemotherapy, which was established as standard of care. Median survival actually improved from 16.8 months with chemotherapy plus trastuzumab to 20 months with triplet therapy of adding pembrolizumab plus trastuzumab plus chemotherapy. And the response rates was 72%. So just to keep that in mind when we're treating these patients in the first line, that we expect that majority of the patient, like almost 72% of the patients, will have some sort of response if we're treating with this triplet regimen. This led to the FDA approval for this triplet therapy in 2025.
According to your recommendation, the patient did receive kind of the triplet therapy in a way with the FOLFOX checkpoint inhibitor and trastuzumab. Patient achieved a partial response, tolerating the treatment very well. However, unfortunately, 9 months on treatment, experienced disease progression with increased number of liver lesions. ECOG PS is still one, it's excellent. Repeat biopsy, as we've talked about before, was done. Fresh tissue sample received an HER2 IHC of 3+, but no other actionable gene or protein alteration was detected. So at this time, Amit, what is the next best treatment for this patient?
Yeah, so just a couple of things. This patient did undergo repeat biopsy and was found to be HER2 positive. This means the patient has persistent HER2 positivity. We have a drug called trastuzumab deruxtecan, which is approved for patients who have progressed on kind of a regimen that this patient got, including anti-HER2 therapy and chemotherapy with gastroesophageal adenocarcinoma progress, and they are still HER2 positive on the repeat biopsy.
Can you talk to us a little bit about Destiny Gastric 01 trial?
Yeah, so Destiny Gastric 01 trial, it was a randomized phase 2 trial which used trastuzumab deruxtecan for patients with HER2 positive gastric or gastroesophageal junction adenocarcinoma who had previously progressed on some of those first-line treatment, including trastuzumab. These patients were randomized into TDXD or trastuzumab deruxtecan or standard of care chemotherapy, typically involving irinotecan or paclitaxel. And it showed improvement in the median survival from 8.9 months with the chemotherapy group to 12.5 months with TDXD. And similarly, the median PFS was also improved from 3.5 months to 5.6 months with hazard ratio 0.47. So this led to FDA approval for TDXD for patients with metastatic HER2 positive gastric cancer who had previously received first-line trastuzumab-based regimen and had progressed.
Thank you for that, Amit. In this patient, the decision was made to administer trastuzumab deruxtecan. Could you tell us about the adverse event of special interest that you need to counsel the patient and caregiver about?
So TDXD or trastuzumab deruxtecan has a unique side effect of interstitial lung disease or pneumonitis. And that's something we should be really aware of. So any patients who develop shortness of breath, right away, we need this patient to be evaluated, get a high resolution CT. And if you think there's a sign of interstitial lung disease, immediately start treatment. Typically, we do like a steroids, and there are guidelines how to treat them. So like for grade 1, we'll start like about 0.5 milligram to 1 milligram per kg of prednisone or equivalent. And similarly for grade 2 or higher, we'll do 1 milligram per kilogram of prednisone or equivalent. The steroid regimen is given a little bit longer. You start this therapy, give it for at least 2 weeks, patient's improving, then do a slow taper over 4 to 6 weeks, and you do a taper every week. So this is not like a short-term steroid treatment, but a little bit longer treatment. The main thing about this is that we need to identify that early. High-resolution CT can pick that up. And sometimes you just need a pulmonary input as well. You might have to rule out other causes of interstitial lung disease, including atypical infections. So may need like bronchoscopies, PFTs, etc. And pulmonary groups can definitely help. And depending on what kind of grade it was initially and how it resolved, like, so if it was like, say, grade 2, went down to grade 1, patient is now asymptomatic, you can still restart TDXT. So you can still give it. You have to give it at a dose reduction. So at that point, so give it at a first dose reduction, depending on what dose you started. So for gastric, the approved dose is 6.4 milligram per kg. And if that's the dose that you started, then you go to one dose reduction to 5.4 milligram per kilogram and so on.
Yeah, the main thing is for interstitial lung disease, one takeaway is you've got to recognize it early. If you recognize it early, you've got to take the corrective actions. Can you tell us about other agents which are coming out for treatment for HER2 amplified gastroesophageal adenocarcinoma?
Yeah, so the HER2 positive field is getting more and more exciting with the newer agents coming up. Similar to BTC, we talk about the use of zanidatamab. So there's a trial called Horizon GEA-01. And in this trial, they're testing, again, as a base of trastuzumab plus chemotherapy and trying an experimental arm of zanidatamab plus chemotherapy with or without tislelizumab, which is an anti-PD-1 block inhibitor. So zanidatamab, as you mentioned, is an anti-HER2 bioapoptotic antibody and binding to 2 epitopes on HER2. So in this 3-arm trial, they randomized almost 900 patients. One is a trastuzumab plus chemotherapy. That's your, kind of a baseline arm. And then arm B was zanidatamab plus chemotherapy. And then we have a third arm where we're testing zanidatamab plus tislelizumab plus chemotherapy. This trial had a dual endpoint of PFS and overall survival. And the median PFS was improved from 8.1 months with trastuzumab plus chemotherapy to 12.4 months with the triplet regimen of zanidatamab, tislelizumab plus chemotherapy. And the hazard ratio was 0.63. Interestingly, the median PFS was also improved for zanidatamab plus chemotherapy compared to trastuzumab plus chemotherapy as well, from 8.1 months to 12.4 months. In terms of overall survival, we saw a significant benefit. With the triplet regimen, the median survival improved to 26.4 months with hazard ratio of 0.72. The data is still ongoing, so we may have more update. Zanidatamab plus chemotherapy showed median survival of about 24.4 months.
Okay. Amit, in your clinical practice, what do you think are the persistent needs with appropriately sequencing HER2-directed therapy for patients with advanced GEA and advanced BTC?
For patients with advanced GEA, the field is getting crowded. The field is getting complicated. It's becoming very challenging to know what kind of HER2 therapy approved for what cancer. We have diseases like breast cancer, where a lot of anti-HER2 therapies are approved. But in gastroesophageal cancer, there are only a few anti-HER2 therapies that are approved. So in the first line, as of today, is trastuzumab plus chemotherapy plus pembrolizumab. And in the second line, TDXD. We just talked about Horizon GEA data, which showed that zanidatamab plus tislelizumab plus chemotherapy might be an intriguing option, which could be available in future as well. The biggest takeaway is do the HER2 testing. When you have a patient, try to get the tissue and do the HER2 testing. And do not start the patient the first line treatment before getting these biomarkers, because really that's how we will decide. Obviously, there are options for clinical trial as well. And then second thing is, once a patient has progressed on the first line regimen, including trastuzumab or some sort of anti-HER2 therapy, I think we have to do a repeat HER2 testing, which would frequently require a repeat biopsy, because many of these patients can lose their HER2 amplification. So they're HER2 positive, and you treated them with anti-HER2 therapy, they may no longer be HER2 positive. And in that case, they'll not benefit from further anti-HER2 directed therapy.
That's very important, Amit. And same thing for BTC. If you look at it, essentially, we should do the HER2 testing for the patients with biliary tract cancer. There are two good options available, zanidatamab and transfusion deruxtecan. We don't know how to sequence these. I think we'll come to know more as time progresses as to how we can sequence these different options. Sometimes what I do in my practice is the patients are coming off gemcitabine, cisplatin, and a checkpoint inhibitor. And if they have a lot of fatigue or challenges with chemotherapy, then I think about zanidatamab just to give them chemotherapy-free interval. But both agents are active in this disease, and it's good to have options to treat our patients.
Shubham, talking about BTC, so saying the anti-HER2 therapies are currently approved in the second line or later setting. Can you just talk briefly about some of the key ongoing trials, and is there a thought of bringing that in the first line setting?
It's very important because about 40% of patients can drop off second line. So let's say about 100 patients were treated with frontline therapy, only about 60 patients or 50 patients might be treated with second line therapy. So we want to try to give the benefit to the patients in the front line. And we have two really exciting trials in the frontline setting, Horizon BTC 302, which is a global trial of zanidatamab with standard of care. So it's basically standard of care with or without zanidatamab. And we also have the Destiny BTC-01, in which TDXT is being combined with Rilvi, which is a bispecific immune checkpoint inhibitor, essentially. So there are different trials, which are global phase 3 trials, which have moved these anti-HER2 therapies to the front line. We're really excited about patients being accrued to these trials and the data readout coming out in the years ahead. So what are you excited about in HER2 positive gastric or gastroesophageal adenocarcinoma?
We'll continue to see the Horizon GEA data from the follow-up. And secondly, if the FDA would approve these drugs, and then we have more or better therapies available for these patients. So also good to see that we are pushing the boundary where median survival used to be about a year for these patients. And now we're almost at 2-year mark already or exceeding that mark. The other thing is we're trying to bring these anti-HER2 therapy in earlier settings. We already have it approved in the first line and second line advanced setting. But there are trials going on which is trying to test anti-HER2 therapy in resectable HER2-positive patients. And there it could make a bigger difference. If we can improve the cure rates, it could have much bigger impact too.
Right. So what are your overall final thoughts?
Testing. That's the most important thing. We need to test on the tissue every time. So before the first line, and if you have treated the patient with anti-HER2 therapies prior to the next line of therapy. So we have drugs that are approved in the first line as well as in the second line. Currently, we have a trastuzumab-based chemotherapy in the first line setting. And in the second line setting, we have TDXT. But as I mentioned, the Horizon GEA data, which is very exciting, which could have zanidatamab plus chemotherapy with or without anti-PD-1 blockade in the first line setting. So exciting times ahead. So Shubham, do you want to talk about BTC and how HER2 positive BTC is being shaped up?
Yes, testing, do the NGS, that's important. Tissue testing is important. I think we have a lot of exciting options for our patients with targeted therapy. In BTC, I like to call BTC lung cancer of GI malignancies. We have a number of targets in BTC, but we will not be able to give any of those drugs to patients if we don't test them. So that's very important. And please do look for clinical trials for your patients in the frontline setting, because there are a lot of exciting molecularly targeted trials which are out there with zanidatamab or with trastuzumab deruxtecan in the frontline setting for HER2 amplified biliary tract cancer. So with that, I'm going to thank our audience for learning about HER2 amplified biliary tract cancer and gastroesophageal cancer. Thank you so much.
Yeah, thank you.
Thank you very much, Dr. Mahipal and Dr. Pant. And thanks to you, the listeners, for joining us. As a reminder, to view the full program on innovations in HER2-positive gastroesophageal adenocarcinoma and biliary tract cancer, a practical skills course on new and emerging targeted therapies on the DESIRA Clinical Education's website, please click on the link in the show notes. As always, thank you for listening.